Father, we thank you again for this camp which has been successful, Almighty God. From the beginning even up to now, Almighty God, we thank you, Almighty Father, for all the interventions, Almighty God, and even for all the wisdom, Almighty God, that you counted upon us. And we speak your blessing for each and everyone, Almighty God, who has been part of this, Almighty God, to see that our patients, Almighty God, have been well taken care of. We thank you for the surgeries, Almighty God, that have taken place all through, Almighty God, even in a smooth way, Almighty Father. Heavenly Father, and we as we listen to today's topic, Almighty Father, may it be a blessing unto us, even for the benefit of our patients. Each one of us have from here with new information, new ideas, and new experiences, Almighty Father. We pray this trust and believe it in Jesus' mighty name.
So good morning everyone. Okay. Drawing nearer the end of the camp. I think there's just 2 more talks, today and tomorrow. And I think some people asked if we could speak about limping children. And it's a very hot topic and it's a very common thing to see in the UK, and I have no doubt it's the same here. And the answer is very easy. It could be any one of these things, plus a whole lot more. And you can read about them all in a textbook. So I don't want to tell you what all those diagnoses are and what the pathology is, because our job as clinicians in the ED and in general practice is to try and decide which of those problems it might be, and secondly, to decide which are important and need some treatment and which do not. So I'm very keen on thinking about differential diagnosis and then narrowing it down with all the clues you could possibly find. And so I was thinking this morning as I walked in, if I'm on safari and the safari guide says, "Did you see a movement in the bush?" And I didn't see the movement. How am I going to know what animal it is? It's not going to come out of the bush and say, "Hi, I'm a tiger." Or it wouldn't say that.
Or a bear.
Or a bear, or a cobra. So the way you might start thinking about what animal it is you consider where you are, what time of day it is, what the vegetation is like, and which animals like that sort of vegetation, how big the footprints are that you're looking at, or you've seen. Looking for clues. And then you can probably narrow down what type of animal that could possibly be long before you've even seen it. And then, with the binoculars, you just need to catch a glimpse to confirm which one it is. And going through a differential diagnosis is a bit like that. You start with a really wide differential, and you're narrowing it down using all the information you get. From the moment you read the referral letter, then the moment you see the child and the family, and then the moment you work out what sex they are, what their background is, and then you start asking them questions or listening to the history. And then by the time you get to the examination, hopefully you've only got a couple of things that it could be. And you can really focus your examination on differentiating between those remaining diagnoses. And you can make it quick and efficient and accurate. And if you need to confirm something with a special investigation, you can do that at the end. So in a limping child, right from the time you see their sheets and you know their age, you can start ruling things in and out. So for example, you wouldn't get a slipped upper femoral epiphysis in a 2-year-old. And equally, you probably wouldn't get septic arthritis, for example, is much more common in a young child. And there's a little graph, a graphic demonstrating the range of ages you might expect to see some things. And what we see a lot of in the UK in terms of hip pathology causing a limp is Perthes disease, and that's got a very narrow or very well-defined age range from about 4 to 10. Symptopofemoral epiphysis, which is much closer to skeletal maturity, and apophysitis, which is a fairly benign inflammation of an apophysis, which is a growth plate attached to a tendon. That's a slightly young teenage condition. Those are just examples. Then, what sex is the child? Well, we know things like dysplastic hips are much more common in females than they are in males. And conversely, Perthes disease is much more common in males. And in the small-born males for their age, and in hyperactive males. So, using that information, you're going to say, well, that's much less likely to be a dysplastic hip. And if you add in other bits of the history, you can work out that it might not be effective. And then Perthes suddenly becomes your major differential diagnosis, and then it's down to you to exclude it, and it is that until you can prove otherwise. Then there's the chronicity of the presentation. Has this suddenly occurred? The obvious thing there is trauma, but also infection tends to come quite quickly in children. They're fine one day and then they're quite unwell the next. Some things are self-resolving, so they will get worse and then they'll already be getting better by the time you see them. Other things occur suddenly and stay bad or even get worse, which is more worrying. The chronic conditions, which started perhaps gradually and just got worse and worse and worse and worse and worse, will just stay constant and won't go away. And there are those that come and then they sort of seem to resolve for a while, and then they come back and they resolve, and they probably haven't gone away, but the symptoms have resolved. And a classic one of those is Perthes disease and apophysitis, things that are related to exercise and activity. So that when in periods of inactivity, they're much less prominent in the child's life. The family don't always say, oh yes, it's related to whenever he plays sport, he gets these problems. Because they don't think like doctors do, and that's why we get training to think like that. So you have to do some of the things, you may think it's obvious, but you have to pick it out of the history because the family don't want to present the information in the way you want to use it. And synovitis, which is usually related to a viral illness, that can come up and down. And if you look back through the history, you find that they've had a series of colds or viral illnesses, gastroenteritis, and around the same time they've been getting pains in their joints. So then you go on and include more, and so you're asking a specific history now, direct questioning. Is there a history of trauma or increased activity? It's an obvious question, isn't it? But it's amazing that families don't say, oh yeah, Johnny fell over, he fell out of a tree and then his leg fell. It's bizarre. Have they had previous investigations for a similar condition or similar set of symptoms? And that's helpful because they may have been diagnosed with a similar thing beforehand. But it can also be helpful because if they've had an investigation and, for example, a previous x-ray has shown normal hips, then it's extremely unlikely they've got dysplasia, new dysplasia of their hip, because that's a congenital problem. And once it's been ruled out as a child, it doesn't come again. It then require later. Have they lost any weight or had night sweats? Well, that's obvious to us. That's really important, isn't it? You're thinking about TB, tumour, infection, HIV, but families don't think like that. So that's a really important question. And those red flags is really important because those are the big group of things that we need to treat early. Otherwise, they become either chronic or a long-term disability. And then there's some specific ones that we're all taught at medical school. You know, paediatric hip pain often, if not usually, presents as this thigh pain or even knee pain, or even beyond the knee I've seen, although that's slightly less common. So never look at a child with knee pain and forget about the hips. Pediatric knee pain is really quite rare before teenage years. Pediatric hip pathology is really quite common, so think of the hip. And then, just because you have a history of something that seems obvious, doesn't mean you haven't got something else. And I've seen lots of patients who've had trauma, they turn out to have septic arthritis or osteomyelitis. Now, are the two actually related? Do you get septic arthritis because you've injured your knee and it becomes vulnerable to hematological spread? I'm not sure, but certainly both can occur concurrently, and it's important to not miss one of those because you think you found the other one. Then, I'm sort of focusing on the things that need treatment now, because of course, if you looked back at the original differential diagnosis, there are things like fractures. I dropped a weight on my foot and now it's swollen and it hurts and I'm limping. Well, that's a fairly obvious thing. So, and it will get better. And equally, foreign bodies in the feet, they're quite common. Athlete's foot, your differential could be huge, but the things that often need treatment so as to avoid long-term disability involve infection and major joints, typically the hip. So I'm concentrating on that now. How do you differentiate between a recurrent synovitis or a reactive effusion versus proper infection in septic arthritis or osteomyelitis? And you know the answer to this. You just have to actually believe your training. So if you're seeing a recurrent, mild limp in a patient that's not become unwell and has had periods where it's completely resolved, then it's unlikely to be a bacterial septic arthritis. If you've got a febrile, conversely, if you have a febrile, feverish, sweaty, grumpy child, you must exclude infection, and it's been going on, it hasn't shown any sign of resolving. The onus is on you to exclude infection. So, what would you see? If it's an infection of a major joint, the child won't move it. If it's a native infected joint, it will be very stiff. They probably won't weight bearing. But there are other causes of not weight bearing at all, including slipped femoral epiphysis, which is in an older age group, so you're already suspecting that, as opposed to septic arthritis. But if they have an unstable SUFI, then they might not go there as well. So then you're examining the child, again thinking about the hip and the major joints. They have a limited range of motion. They probably have an effusion. That's by far the most typical reason, but that doesn't mean they're septic. They can have an effusion without having a sepsis. So you need to differentiate those two. So we've already talked about the flushed and miserable child. I think I've got a photograph. That child is English. It doesn't look quite normal. Do you see? It just got red cheeks and wide eyes and slightly staring. Just a little clue that they're not quite normal. And if you're not sure, ask mum, because mum knows what they normally look like. This child, you see they're very unhappy, and you can see the difference in posture between their legs. And if you watch that child for 30 seconds, you would see if they had something wrong with one of their joints, you'd see they didn't exchange the posture. It was always the left hip that was externally rotated and flexed up. And you just have to watch and observe, because children aren't usually very asymmetrical unless there's something wrong. I do lots of baby clinics where I scan babies, routine scans for ultrasound for hip dysplasia, and they're really the whole time. You can't keep them still. They never lie still and cry, unless there's something quite bad. Then, of course, you'll lay your hands on the child, and they can't say, ow, it hurts here. So you have to have high perception of, are they behaving as I would expect a child to behave when I feel their major joints or move their hips or feel along the long bones. And it may be very subtle, just little, not pulling their legs away, but just little movements where they just get a bit fidgety when you touch one point. You have to go over it again, and that's repeated. It's all very, very subtle, even in someone who's very, very sick. And then, of course, you look over to the soles of the foot and anywhere else involved in weight bearing. In an older child, if you think about popsitis, there's popsitis in the heel bone called Sever's disease, so you feel there. The tubercle, which is called Osgood-Schlatter's disease. I'm sort of mixing this up a bit because I'm just dealing with the examination. I'm not dealing with a particular diagnosis. So I'm trying to get you to think about how you narrow down your diagnosis. Now, if you've got a baby, you're not going to be thinking about Sever's disease because that happens in 11-year-olds. But my point is made that you have to keep all the information in your head, to narrow down your differential diagnosis. And then another very specific thing, can you see that picture? This is a teenage boy, he's a bit overweight. And as the clinician flexes up his hip, he cannot keep it straight. This is called obligatory or obligate external rotation as he flexes. And sometimes they abduct as well. And you cannot straighten the hip. You cannot straighten the shin to be in line with the spine. And if that's not the case on the other side, that is pathognomonic of a slipped up femoral ipsis. You probably all know that, but you can't miss that. That's a suing offence to miss that. So anyway, by now you've got your diagnosis, or at least you've narrowed it down to one or two things. Usually that is, there's a hip effusion, is it septic, is it not septic? That's the usual one, but it could apply to many other joints. So in that case, special investigations can be of help. You can blood screen for infection. If you're suspicious of infection, please do blood cultures before we let the paediatrics. In our country, before we let the paediatricians see the child, because they'll start antibiotics straight away, and you're less likely to get a good culture. Consider tumour, and you may find that calcium T phos or LP raised in bone tumours. And get an X-ray if you think the joint is involved, especially if they are over the age of 5, because you see much more there. And that may indicate an effusion of the hip with a widened joint space. Obviously, if you suspect something very specific like a foreign body, that may, in the foot X-ray may be helpful. In teenagers, you can exclude a slipped up femoral epiphysis. In younger children whose history you don't know with chronic problem, you will exclude dysplasia. But some things won't show up on an acute X-ray, like Perthes disease, avascular necrosis. Sometimes usually sepsis won't show up on that. Things like osteomas and small tumours, benign tumours don't show up. And you either need to repeat the X-ray later or get an MRI scan. Who knows about Cocker? Anyone know about Cocker's paper? Mr. McCall knows, okay. Well, that maybe is too specialised. But I'll tell you anyway. Cocker is the name of the author of the paper, and he did very low grade study. He observed, I think 50 or 48 children in whom he did these investigations, and then later decided whether they did or did not have septic arthritis. So it's very low level evidence. However, it's widely quoted and often used. And his 4 criteria, which are on the left, he correlated with the actual outcome of whether the child had septic arthritis of the hip or not. He found that if the 4 criteria are having a high temperature, being unable to weight bear, which is very non-specific about whether you're using pressure or not, whether you have a white cell count higher than 12, and an ESR of over 40. And on the right is your percentage chance of having, or the child's percentage chance of having septic arthritis, if either 1, 2, 3, or all 4 of those factors were present. So if you had all 4 of those findings, you almost certainly have septic arthritis. If you have 3, you have a 93% chance, and then if you only have 2, suddenly it drops to 40%. So it's just really reassuring to have something that you can hang your hat on and say, Crocker's criteria suggests you do not have septic arthritis. Nowadays, of course, we don't really know what he meant by weight bearing, and we in the UK hardly ever use ESR, so it's not as useful as it might be, but it's often quoted, and that's what it means.
So Guy, there must be another criteria, like you suspect hip pathology. Because
Yes.
if you've got pneumonia,
Yes, yes. Right. You must have a child presenting with pain, or learning pain. So sort of. So anyway, you've done all that, and often by then you finish the diagnosis. Your history, index of suspicion, and your examination, and if necessary, your special investigation, they're all married up. And so you've got your diagnosis. But in the process of narrowing down a differential diagnosis, hopefully you've saved yourself time, and you've saved yourself and the child unnecessary investigations, because you started at the beginning and narrowed it down. Usually, the only reason that you don't have a diagnosis now is because you can't decide whether the child has got a septic hip, or not a septic hip, or indeed a knee or an ankle, but it's usually hip. And the other thing is, I haven't really talked about here, is a discitis or some sort of spinal pain which can cause the child pain. But typically it's one of the synovial joints, and usually the hip. So what are you going to do? You've done your blood cultures, someone started intravenous antibiotics. The child's looking a little bit better because they've had systemic treatment, but you don't know why or what the differential, what the diagnosis ultimately was. So the real question then is, how are you going to find out? Because anything from here on is quite invasive. You could use an ultrasound to look at the hip and see if there's a swelling in the hip, but it doesn't tell you whether it's septic or not. You can aspirate under ultrasound, but most small children don't find that very acceptable. So then are you going to do an MRI scan, which in many small children needs a general anaesthetic, or do you say, well, I'm going to do a general anaesthetic anyway, I might as well just take you to the theatre and aspirate the hip in the theatre, and then I can proceed straight to a washout or a flush through if it's positive. But that doesn't tell you if the child's got osteomyelitis and osteopenia versus a hip sepsis. So this is where it's really unclear. It's also where you start to spend a lot of money and time on these resources to diagnose the patient. And it's also where the risks go up because you're talking about general anaesthetics and the anxiety goes up in the family. And it also depends on your local resources. So I would imagine here you can't just say, well, just roll them into the scanner under a general anaesthetic. I would think that would be a nightmare, because the MRI is probably on the other side of town. How?
It's narrow and narrow.
Okay, so that's all right. So often the child's unwell. Your MRI scanner is in another town. And you need to make a decision whether they need a washout. So I would think in this environment, you'd probably say, if you've got to the point where you can't exclude septic arthritis, you take it to theatre. You'd aspirate the hip under you do repeat aspirations and flushing?
We make decisions in the box. We go together to do an applause and we go together.
Yeah.
We hardly ever we have had special needs. We make decisions.
Yes.
We make them.
No. Well, that's what we do in the UK.
And they're brought together because
The trouble is they have approximate frames osteomyelitis, which you haven't been able to see on the X-ray. So what you might see then is they have a sterile aspect. They have an infusion, but you wash them out because it's sterile. And then
we prefer washing out.
yes, exactly.
Either way, an osteomyelitis is a huge emotion.
Yes.
It's a emotion and bring about.
Yeah.
So either way, as you find.
And sadly, that sometimes means you've got to go back and do a second operation to treat the osteomyelitis, and you can't get that first time. So this is where the problem becomes more complex, and the experience counts for so much, because the more experienced person will be able to probably tell between whether they're pressing on the infusion or on the bony stuff, whether it's a subperiosteal abscess, and when they're operating, whether the effusion looks like it's pus or whether it doesn't, whether you then suspect the adjacent bone. Okay, so, and then on the subject of septic arthritis, in the UK, the treatment episodes are getting shorter and shorter, as long as it's been effective washout and no osteomyelitis. We down to about 2 weeks ago IV antibiotics. That's what you do for oils after that. So that's probably based on good up-to-date literature, which you would follow just the same way as we would follow. There is evidence from Blantyre, I think, originally about 10 years ago, where they did, especially for knees, zero washouts. Zero sprinklers. I think flushing was in-house joint children, and they got the same results as open arthritis. So that is something. Yeah, we do as well, but I think the evidence is there. So, sometimes, having said all that, you cannot find, or you simply cannot find the reason the child is limping, especially in the chronic and relapsing ones. And so I often start my consultation with, if I've looked through all the previous notes, I've been referred a patient, I've looked through the investigations, I've looked at the x-rays, and I then meet the family. Sometimes start by saying, my job is to make sure that there is something here that will get there by itself, and that there is not something which I need to treat in order to avoid a future disability. So if I don't find the answer and I can't tell you what it is, I will still be pretty sure that you don't have, or the child doesn't have anything that has to be treated. And as long as they're prepared for that answer, then it makes it much easier to say that we've excluded everything that matters, and I'm sorry I don't know what the answer is, but I'll keep you under review, or I'll give you an open appointment and come back if it doesn't get better. But most things for children get better by themselves. Sometimes, if I suspect this, I'll bring them back in 6 weeks and take another x-ray and examine it again, by which time you might start seeing some kind of fracture or some sclerosis of the epiphysis. Sometimes I think, especially if there's a family history of autoimmune disease, or they have some other autoimmune condition, or it's behaving like a migratory polyarthropathy or something like that, I might send the rheumatology paediatricians, or just the paediatricians, to investigate them for juvenile arthritis, which is uncommon but not rare. And sometimes we just accept that there's a synovitis, there's no evidence that it's being infected, and we watch and wait. So PAL means pearls of wisdom. Oh, that's a bit grand. But what I take away from this is that if you know that list of your surgical sieve, the differential diagnosis, and you just start thinking about that from the moment you open the letter or the notes from the GP, and you start excluding things, and you'll end up with a very short list, which makes it so much easier to work out what might be going on. So use all of the tools available to narrow it down. Only using investigations at the end to confirm diagnosis. Use interval assessments, especially with inpatients where you're not sure what's going on. Assess them regularly. Know what they've been treated with in between your assessments, but assess them regularly, and you will see a direction of travel. You will see them getting worse, and then you know you need to do something, or you'll see them getting better, in which case you can afford to watch and wait. And always get your blood cultures going on if there's any chance of there being sepsis. So that's what I'd say about that. Thank you very much. Would anyone like to ask any questions?
Thank you very much. That was for the presentation. I wish to invite any of the surgeons here would wish to make a comment in regards to the discussion.
The first time you open the letter, you look at the notes and excluding things, and you're taking things away, and you're thinking what it could be. That obviously comes with knowledge, time, and experience. How long in practice did you feel more confident being able to do more effective?
Well, do you know what? It's interesting on the confidence. The trouble is you can be overconfident. So as you get more and more experience, the temptation is to say, oh, I've seen hundreds of these 5-year-old boys who present in this way with this story and they come from that town, they always have purposes.
Yeah.
That's the danger. So the answer is there's probably a sweet spot where you have to stay on your toes and avoid that trap. But in general, thinking of it philosophically, you'll be able to narrow your differential more rapidly the more experienced you become. And you may need fewer investigations the more experienced you become. But the process is the same. And it doesn't mean that you can't do it as a very junior clinician, because as long as you start with the differential diagnosis, you just have to look more carefully and need more clues to exclude each one. So if you were trying to exclude infection, you might need to ask for more detailed history, get more investigations, perhaps see the patient more frequently to see that they're getting better, not worse, etc., etc. And you might have to ask for help or a second opinion from someone more senior. And as you become that more senior person, you just get through the differentials more. But I think the process is really important. If you go and see a patient with an open mind, with a differential that long, and you have to think of each one in succession and then examine for that, and then go, or you just do a hip examination. All you're going to end up with is this patient's got a stiff and painful hip, and you've then got to go back to the differential list to start trying to exclude what they are. So it's just a thought process I'm really trying to advocate.
Is there a possibility of having an algorithm the same?
Yes, but it would say more or less what I've said. I think we start with that big differential, and it's not the same as starting with the diagnosis, which is the way that Dr. Christoph and his algorithm was, I start with the diagnosis, I'm going to decide which treatment algorithm to use. So you're starting narrow and expanding, whereas what we're doing is starting broad and trying to narrow down in terms of getting to the diagnosis. So the treatment algorithm is easy to do, but with the diagnostic algorithm is much more.
Yeah, the non-big association for me is age. I'm thinking age first. What's likely? then I'm actually thinking, what age the child walk? That's really important, isn't it? Developmental, there's so much cerebral palsy. And then just thinking of the surgical sit. So is this neurological? Is it infective? Is it traumatic? And often I forget traumatic because the history falls so late. So I think that, for me, it's a non-pediatric specialist where I'm struggling. I'm with a little mind, that's how I do it. Because it's so age-specific.
Anyone else? Yes.
In your practice, in instances where you have viewed a patient with those complaints, like they have come, they are limping, but you're not able to get a conclusive diagnosis, how soon do you want to review them?
Good question. So what I normally at the end of the consultation, I have got a conclusion. I still have a list of things that I want to exclude on a second visit. There's no point in having a second visit, and just to reassure the family, I think the more confident you get, the more you can say, you call me if you've got a problem, I don't want to see you team. But if there's something specific that I want to rule out on a second visit, then it will depend on what that is. So it will depend if I need a repeat investigation on an X-ray, in which case there's 6 weeks, for example, in both disease. If it's something that's like, for example, an apophysitis or a confirmation patella or some other teenage thing, I'm trying to tell them to go off and get some physiotherapy, to modify their lifestyle, to take some analgesia, but there's no real risk of them coming to any harm. I may say, come back to me in 6 months if you haven't got any, or I will see you in 6 months to a year. So it really depends. Now, if it's something where I'm thinking, there's still a doubt in my mind whether this could be infectious, and I want to see, it seems to be getting better, but it might just get better and relapse. It may be much shorter if it's infectious, because I really want to treat that early. And then the last group is someone I sent off for an investigation, so it'll be as soon as the investigation is done, and I will ask for the investigation urgently or not urgently, according to how suspicious I am. Does that help? It depends, it sounds. It's a really open-ended topic, and there's no easy algorithm, which is what you want. So it's about developing your thought processes and getting experience and enjoying it, because working with children and their families is really, really satisfying. So, and families really worry about their children for obvious reasons, and to be able to reassure them and just to reassure them if there's nothing wrong, it's really satisfying. And be able to pick the ones where you actually have to do something is really satisfying work. Thank you.
Good morning. Today, oftentimes, the only thing the child will have, or the parent will present to is about the child. In adults, we don't discuss about language. Adults, they do. Sometimes adults will come with very specific things. But one day, one morning, a mother will notice that the child has been otherwise normal, has started breathing, and they have nothing else to go on. And so they come to you because they have noted a change in age. And like Dr. Guy said correctly, if a mother says that your child has a problem, that will be it. Even if the baby is 2 days old, they'll know. And if you ask them exactly what do you think the problem is, they may not inform you what it is. But they know something has changed. So you've got to think about it and think through. So I think you have tried to really simplify a difficult topic. So you have done a good job, especially compressing it in such a time, because it can be quite complex. The other thing, of course, I would want to emphasize at this point in time is that for all of us, whether we are talking from the point of view of being an orthopedic surgeon, a doctor, another trauma or physio, or a father like me, that if you are told, or if you think, if someone claims that there was trauma, for example, and every day I get to hear that my son fell, do not think that that is what caused it. Do not assume. So I see lots of times children coming to me with a backslap or brace or plastic, the traction exercises, osmotic. And the reason is the mother saying, or the teacher saying, or the other child saying, child fails. And they have pain in their body. So you say there must be a fracture, and you do an X-ray, you can see one. And first of all, you think you can see it. Even when it's appropriate, you think that must be a fracture. And if you can't even see appropriate, you think it's because it's a little darker, and maybe your eyesight is starting to fail. But there surely must be a fracture there. Or you think it's just like increased. Actually, children fall all the time. So if a mother tells you child fell, of course child fell. They fall all the time. So there's no news about children falling. And when you get children who say, you have one doing something, but the mother said, I think that the father said, you didn't tell me, but I got to know that 3 months ago, you actually had fallen off the spectrum. Children fall off like every day. So that, there's no news about it. So do not take that and say it is because we fall. You still need to go deep down and think about the causes, because almost all the time, irrespective of what the diagnosis is, whether it's a Parkinson's disease, whether it's osteogenic sarcoma, you had an osteogenic sarcoma in the world recently. And the family was swearing. This was because the father was actually saying, I blame myself. Because there was a time I had hit my child here, and that was 2 years ago. There was a bit of swearing. He says, I know I'm to blame. I'm the one who did the child. And if you want to believe the father, and you want to tell him to go and repent, then you got to think, yes, the father might say, I'll hit the child. But think beyond that. Because almost all the time children fall, they play and fall. So do not be confused, sidetracked by the fact that child has some trauma, post-trauma disorders, especially in a place like this. People are going to Grey Scouts or groups, and so they have had a thorn prick. And then you think it must be the thorn prick. And yet this could be students coming. I think that, like what Dr. Christopher was saying, age is a big challenge. So child comes at 11 and he points a lot of symptoms, capture from me too. And then you think, 12-year-old boy, Parkinson's disease, you think unlikely. So you won't start thinking, mind become a sleep capture of human diseases. And many times I don't give anything, even for a very severe limping child, and they improve. Traction of facilities. So children come from class 6 to form 2, and they report, and we see hundreds of these patients. And they come, and the mother is very worried, because they saw the child yesterday, they noted they were going to school, and they were limping. And another day, they were doing the last week, or the teacher reports about that. And everybody is worried, and then you come and discuss with them. And sometimes I don't even any experts at all. I look at the child, I touch the tissue to the and sometimes it's even swelling, and you don't want to do no x-ray at all. I mean, everything is in keeping, so you don't need no radiology. It's worse when they come with it, but sometimes they don't. But if you and reassure them, you'll be surprised. They walk out of the clinic not living. And even if they do, you even give proof and variety, and they don't take it because they understand all the issues. And I tell them the child is 12, maybe come back when you're 17. So the appointment Dr. Mutiso is asking, I say, see me after you finish Form 4. If it is still there, you see what we do. And the next time you read them in the streets, and they are saying, how you see what happened to your limb? They say, limp? Was I limping? Because now they realize. Because anxiety makes them even feel worse or get worse. And the mothers, specifically, are very strict. They say, the other day you were limping, and I saw you. I looked through the window, and I saw you play. You won't fall again. Please don't try that. So the mothers will keep monitoring, even following the child to school. They tell you to come and talk to the teacher. Just know that they are playing in the field. And then they will get severe warning. They know what I know what you have been doing during the day. Now you are coming and even limping. And I keep reminding mothers, children must play. If they limp, then they do. If they have appendicitis, when they are in pain, they will not play. If they are not in pain, let them do. And many times it's the mother I need to cancel rather than the child. So the limping child will always the limping child. Like I say, whether it's a doctor, parents or aunts or uncles, just friends. And it is it's an important topic. But it is that one day when you miss your osteogenics at home, or you miss a sleep capital hemorrhage. And then the next time the child is having a permanent problem or a death sentence from the osteogenics at home, that you will miss sleep for a day. So you must not assume this, and I agree completely. Just because people have traction anxiety, then don't think that every 12 years old you have traction anxiety. Because it's the same region when you get osteogenics at home. It's around them when you get osteogenics at home. So if you think every limping child is traction anxiety, it's possible to have disease. And then you miss the osteogenics at home. Nobody will forgive you, not even God will forgive you. Because it is a death sentence. One is something that you are seeing through, and you pass through that stage. The other one is a death sentence. You miss it, and you lose the life. That's why it's so important for us to think about the limping child. And the next day, you see somebody saying, "Man, to a 12-year-old, please remind him, he's a limping child." It's nothing like manning up. They are 12-year-old. Please look at them and magnifying glass. Because if you need something at that time, it will give you only this much time. For example, for students at home. And maybe sleep capital hemorrhage, and then this child is going to have a lifelong limb or damage. And then you will do one simple screw that takes you 45 minutes to fix. And that's it. And then you have a child, somebody who will not remember what they had. So that's why the limping child is a serious topic. It's a topic that we must always think about, and I don't know, I can see a lot of people from physio and other trauma. If a child comes to you and they are limping and it is not obvious that they have a fracture, it's not a fracture, please refer those children. Do not assume. Especially do not just generalize. Don't just put. I mean, I've had the result in 2 months or 3 months. Unfortunately, quite a number of septic arthritis. It's not a very common thing that we see, but we have seen it really.
It's not common.
It's not common. We haven't been seeing it much. But all of a sudden we have seen 2 or 3 of them, and it is something we really want to be aware of. And the people in the world around, Dr. Mtisi will tell you how much time you have spent just trying to discuss why you go to get it right the first time. Because if they come from London and they come to you, they have septic arthritis, and you see them and let them back, the next time you see them, you'll be doing an arthritis. Because they have been treated, even if the infection kills, they are going to have a flexed hip, they are going to have sometimes ankylosis, and that does happen. And for us, sometimes occasionally it's a TB joint, so you also need to know the difference. And of course, we need to emphasize it because I don't think someone who see a trauma in the UK. We don't see it a lot, but something to see, occasionally see a TB here. So it is something that a limping child is a broad diagnosis, but we go to narrow it down, and there are many times in the transits of the writers that you may not find the diagnosis at all. But that always must be the exception and not the rule. So you do not see a child who is limping, and when you check in 2 minutes and do 1 or 2 tests, and there's nothing you can find, then you say transits and writers. Because that's the easy way out. You need to look again and think again and drink again, and maybe see them again if you are sure, just to make sure you miss something that you should have gotten. And I think that this is a topic we need all to think about and make it a guide for doing justice to that.